Right, we will now begin the webinar.
Good afternoon or good morning and happy St. Patrick's Day. My name is Deborah Coffey and I serve as chair of the National Alliance to Stop Impaired Driving, known as NACID. I'm also Chief Government Affairs Emeritus at Smart Start Ignition Interlock. For more than 30 years, Smart Start has led the way in advancing ignition interlock technology and alcohol monitoring both nationally and around the world. On behalf of our leadership team, I would like to recognize our board members and partners. Secretary Kristen Smith, Head of Global Road Safety Policy at Uber, Treasurer Jerry Miller, Executive Director of the Institute for Traffic Safety Management and Research at the University at Albany SUNY, NACID Director Darren Grondell, Senior Vice President of Traffic Safety at Responsibility.org, and NACID Administrator Christiana Falcon, Senior Manager of Traffic Safety at Responsibility.org. NACID was established in 2021 as a partnership of stakeholders working together in a public-private collaboration to eliminate all forms of impaired driving, with particular focus on multiple substance impaired driving. NACID works collaboratively to advance effective and proven strategies such as DUI system reform, improved DUI detection, and the expanded use of data and technology. NACID provides national leadership to expand testing among impaired drivers, train criminal justice practitioners, strengthen toxicology laboratory capacity, and implement programs that increase the likelihood of recovery while reducing recidivism. Our work includes state and federal advocacy efforts, public awareness, and educational initiatives like today's webinar, and support for the implementation of effective programs across the states. We are a member organization that brings together law enforcement, prosecutors, judges, toxicologists, academics, safety advocates, industry leaders, and corporations. If you are not yet a member, we encourage you to join us. Membership information can be found on our website at nacid.org. On behalf of NACID, welcome, and thank you for joining today's webinar on the importance and growing success of evidentiary oral fluid testing. As drug-impaired driving continues to challenge both public safety and public health, oral fluid testing has emerged as a powerful, reliable, and scientifically robust method for identifying recent substance use. Over the past decade, evidentiary laboratory-based oral fluid testing has advanced significantly, delivering high analytical sensitivity, accurate detection, and defensible results suitable for courts, policy decisions, and large-scale traffic safety programs. Unlike roadside oral fluid screening devices, which are designed to provide rapid, preliminary results to support enforcement decisions, evidentiary oral fluid testing is conducted in accredited laboratories using validated analytical methods and advanced scientific instrumentation. This process provides confirmatory level accuracy and legally defensible results. The distinction is critical for ensuring both fairness and scientific rigor in impaired driving investigations. Again, thank you for joining us today, and thank you for the work each of you do every day to save lives on our roadways. On behalf of NACID, we hope you enjoy the webinar. Amy?
Thank you so much, Deborah. We really appreciate your leadership with NACID and just having this opportunity to bring this webinar to all of you. I am Amy Miles. I manage the regional toxicology liaisons as well as work as a program project manager at the Wisconsin State Laboratory of Hygiene here in Madison, Wisconsin. Without any more hesitation or delay, I'm going to turn this over to our first speaker, Jennifer Limoges. She is the Associate Director of Toxicology at the New York State Patrol Forensic Investigation Center, and she has been really one of the great leaders and those that have kind of driven this initiative of evidential oral fluid forward for all of us. So I look forward to hearing from Jen, and I'll let you take it from here.
Great. Thank you, Amy. And thanks for the opportunity to share what's going on in New York State related to evidential oral fluid program. Next slide, please. So the biggest thing to think about if you are looking to implement oral fluid into your state or into your jurisdiction is really, I can't stress enough to engage all the stakeholders. This is key. And there's so many. You think about kind of that traditional three-legged stool of law enforcement, toxicology, and prosecution, but it goes beyond that to the other people in the court, the judges, the defense attorneys, your highway safety office, and all of those resources that you have. And for us, it can even expand into probation and parole and other areas. So engage all the stakeholders as soon as possible if you're even just starting to think about this. Next slide. And one of the things to think about with those stakeholders is how you educate them and how you engage them is going to depend on what role you serve and what's your expertise in this area, but also understanding what is the knowledge level of that audience. Your toxicologist's knowledge level on oral fluid testing is very different than your judge's knowledge of oral fluid testing. And where are they getting that information from? How much of that information is coming from sales reps or coming from scientists or coming from social media? And then also the real big thing is, what are the priorities of all the different stakeholders here? And is oral fluid something that can help solve problems or improve traffic safety in your jurisdiction? Next slide. So as Deborah mentioned, there are kind of two areas. You've got field screening, which is kind of pre-arrest, can be used for probable cause. It is not what's going to be used is what we call the evidential sample, which is similar to many states use blood, some use urine, and this is looking at oral fluid as an additional option, which is going to be your laboratory-based testing. These are not instant results that you can get at the roadside or at the police station. So this is going to be similar to how blood testing is done in your state. And the advantage with oral fluid is really that it has a very similar detection window to blood, that same time frame, versus urine, which can provide evidence of drug exposure for days to weeks. Blood and oral fluid are down in that more hours kind of range, maybe out to a day or so. So it has that similarity to blood in the detection window. And so we're going to focus on what we've done with evidential oral fluid here in our state of New York. Next slide. So some of the first things we had to consider when we were looking at this is just, is oral fluid in your state statute, or is your statute limited to blood or urine? Some have any biological sample. There's a variety out there. So you need to know what's in your statute. This for us, fortunately, was not a hurdle. We had it in our statute already. You need to consider what resources the labs have in your state. Do you have one central lab? Do you have many labs throughout the state? Here in New York, we have 9 different forensic toxicology labs that are involved in impaired driving. You know, is there case law related to oral fluid? What are the costs? What are the benefits? And what are the challenges? You really want to see, you know, what problems do you have or challenges do you have? And is oral fluid a good fit for that? Next slide. So that was what we did first, is why were we looking at evidential oral fluid for our state? What are the problems that we need to solve that oral fluid could be part of that solution? Next slide. So for us, we have very convoluted traffic safety laws when it comes to who can do a blood draw. And the bottom line, this is quoting from our statute, but it requires certain medical training or certifications to do that. The phlebotomist who draws your blood for cholesterol cannot just draw a blood for an evidential sample in our state without being authorized by a physician or a certain type of nurse. Different nursing levels, LPN, RN, NP, all have different authorizations in our statute. So it can be very complex. And if it is not drawn by someone who has those credentials, that evidence can be inadmissible. And we've had that in some high-profile cases. Next slide. We also have questions in our medical facilities of who's going to pay for that blood draw. Oftentimes, the medical staff may not be compensated or given time off to provide testimony. We can have delays in accessing that authorized personnel. In a hospital, if you go to the ER to try to get an evidential blood draw, they may be too busy with emergency situations to do that. We have hospitals who have refused. We've had hospitals where they have to be admitted as a patient first. And all of these things delay getting that sample. And as many of you know, the toxicology sample timing is critical. The body is destroying the evidence as time goes on. And so time is essential to get that toxicology sample as early in the investigative process as we can. Next slide. What we see in New York, this is just some data during our oral fluid pilot, but we looked at the blood collection times, and we averaged 3¼ hours from the time of the incident to that blood draw. We had one that was out at 6 hours and 45 minutes later. So that is a big delay, and evidence can be lost during that time, especially the active psychoactive drugs. Next slide. Another trend we were seeing in New York is that the refusal to provide a chemical test sample has been steadily increasing over the years. And so while oral fluid is not going to solve the problem of the subject who does not want to give any sample at all, they're just going to refuse to give evidence, there is quite a few times where we saw people willing to give an oral fluid sample when they refused to give a blood sample. Next slide. Whether that was from fear of needles, I'm not going to go to the hospital, there's COVID in the hospital, like all kinds of fears, but they did agree. So during our pilot program with oral fluid, we collected blood and oral fluid from the same subject, but we tracked what happened when all we got was oral fluid without that paired blood. And 13 of those they couldn't get a blood sample, that they just could not get a sufficient draw, whether it was poor veins or whatever the situation, they could not get enough blood sample out. And 10 were where subjects refused to give an oral fluid or refused to give a blood sample, but were willing to cooperate with an oral fluid sample. So, that can help us get some type of evidence in those cases. Next slide. So we knew why we thought oral fluid could be a good part of our traffic safety strategy here, but so how were we going to do that? Next slide. So we fortunately have a great relationship with our highway safety office here in the state and have been well resourced with support from them to have toxicology services. And we were able to develop methods to test for the same panel of drugs that we test in our blood samples, we could apply to oral fluid. And the trick with oral fluid testing for laboratories is you have very small amount of sample to work with, and that sample is diluted in that buffer as part of the collection device. So it took a while to develop those, but we have 3 methods that can cover all of the drugs in our panel. Next slide. But the biggest part in launching a program, or if you're considering that, even if you're just starting to think about it, you're attending this webinar to learn a little more, is start talking about it now with all those stakeholders. What we did was started to incorporate oral fluid into some of our routine trainings that we do for law enforcement or attorneys, where we talk about the difference, say, between blood and urine. We started talking about oral fluid too. 1 or 2 slides in the presentation. But then as we advanced, once we had our methods validated, then we started ramping it up and really educating them on the specifics of oral fluid testing. Next slide, please. So who were our stakeholders in New York? Well, fortunately, we already have an Impaired Driving Advisory Council that was in place, and that included the vast majority of stakeholders. And so we started the discussions in that group, and then from that, we created an oral fluid working group that was focused on law enforcement, toxicology, prosecution, and then also our data collectors. And then we also have a technical working group of all the toxicology lab managers that meets quarterly. So as our lab at the state police started pushing forward with oral fluid, we could keep all the other toxicology labs in the state aware of what we were doing, how we were progressing, and what was happening. Next slide. So where did we focus our outreach and education? Anybody who would let us. We were there. We were talking about it. So we have a New York Prosecutors Training Institute where we were able to do several webinars, both live and on demand. We have the opportunity to get out to our judicial trainings through our judicial outreach liaison. They have an impaired driving seminar for town and village justices where we could start educating them about oral fluid. We collaborate with our state DRE coordinator, and we're in the regular class as well as their recertification trainings. We work with our Stop DWI partners, our Highway Safety Conference, our Law Enforcement Conference. So anybody who would have us, we were out there talking about oral fluid. Next slide. So this is just a little bit of a timeline. Is we started way back in 2018 with just a workshop and invited all those stakeholders, and we brought in people from other states. So we had people who had experience in oral fluid drug testing or in research for that, and as well as this was for roadside screening and evidential, and just educated people to see what they thought about this. There was a tremendous amount of interest after that workshop, and so that's when we created that working group. And then as we got our methods almost through development and through validation, that's when we started really all the targeted training to all those stakeholders. And then in September of 2023, we launched a pilot program, which was really kind of just, I call it a soft launch, to educate and get people used to it and collect data. And then after that, in July of 24, we launched the program where oral fluid is a sample on its own, doesn't have to be with blood, in our impaired driving cases. So next slide. Created an FAQ, and that's on our public website. After following up on the webinar, there'll be an email that has links to this, but there's also a QR code. So again, just resources for our stakeholders and customers. Next slide. So the pilot program we launched, the goal was really to get people familiar with oral fluid, but then we also wanted to identify if there were any additional training needs or hurdles to a broader implementation. And of course, we're scientists. We wanted to collect data. Next slide. And the QR code on that last slide also gives you a high-level summary of our pilot program. But we had a statewide program through the state police. So it was one agency, but statewide impact. We chose to limit it just to our DREs collecting the oral fluid because they're the most trained and most committed to traffic safety. Our final program obviously is open to all law enforcement, but we focused with the DREs during the pilot. We wanted to do it at least 6 months and at least 100 cases, but we had fantastic response from our DREs, tons of engagement, and we had 244 samples over an 8-month period. And the focus was on misdemeanor DWAI drug cases. Next slide. We had blood oral fluid pairs for 201 of those samples and had an excellent correlation for positive. If it was positive in one sample, positive in the other for at least one drug, and over half of those were positive for all exactly the same drugs in both specimens. The 3% that did not match were right around the cutoffs. So where you had indications of one drug, say in blood, but it was just below a reporting cutoff, so it goes out as undetected, but it was just above the cutoff in the oral fluid, or vice versa. That's where those differences ranged. We didn't have any problems with sample collection. You know, occasionally this indicator might not turn blue. There is a little bit of challenge with some of the subjects are highly impaired, and so they have trouble following directions or holding the stick in their mouth for 10 minutes or till it turns blue. They just kind of give up. I don't want to do this anymore. So a little bit of that, but overall, law enforcement found it very easy to conduct the sample collection and excellent subject cooperation. Next slide. So what were the benefits for oral fluid for New York? It's really that easier collection of the toxicology specimen, doesn't have the hurdles of blood. You don't need the medical personnel to do that for the collection. And then subsequently at the back end, that's one less person needed for court. Anecdotally, our officers do report better cooperation of the subjects. It is much less time. You know, we have a lot of rural areas in our state where the nearest hospital can be an hour or two away to get that medical staff to draw the blood. So a lot less time for the officers. We do have some urine testing in our state for drug driving, and we'd like to see oral fluid eliminate the need for that. We feel it's a much better specimen than urine. And we found it to be cost effective. The kits that our agency is using for oral fluid collection run them about the same cost as a blood kit. When it comes to testing, we're doing positive or not detected in oral fluid. It's qualitative analysis, so that is actually much less expensive than quantitative analysis, which is what we do in blood. So there are a few benefits across the board for this. Next slide. So finally, we launched in July of 2024, where oral fluid for the state police, for our troopers out on the road, they can use this as an option in misdemeanor, non-injury drug driving cases. Blood is still the gold standard for toxicology. We want blood in any fatal, serious injury, any felony case. We'd love to see them get oral fluid in addition to blood in those cases, because sometimes we can get that earlier. But oral fluid is an option on those misdemeanor non-injuries. And then in July also, we opened up those services to any law enforcement agency in the state that uses our laboratory can submit oral fluid samples. And so our traffic division, as well as the lab, are sharing a ton of resources, protocols, training videos, all that with local law enforcement agencies to help them establish their programs. Next slide. So where are we at right now? We're a year and a half into the program. Oral fluid is now approximately 30% of the lab submissions for impaired driving cases. We received almost 1,000 samples in 2025, so law enforcement has rapidly embraced this. Besides the state police, we're at over 30 local police agencies that now submit oral fluid in addition to their blood samples. And we've had, it's hard to track all the legal stuff, and you're going to hear from our traffic safety resource prosecutors next, but we have had 3 FRI hearings that I'm aware of where the request for a FRI was denied. We're a FRI state, not Daubert. We have had 1 trial. We're hoping to get the decision published, but it's not necessarily a court of record. And as I said, we focus these samples on misdemeanor non-injury cases. So these are in town and local courts where often they are not recorded or published cases. So it's a little bit harder to create that record that other people can see. But in that trial, the oral fluid went in just like any other blood kit as far as admitting the evidence, admitting the report, and having that expert testimony with it. So that's kind of my snapshot on an evidential oral fluid program. I can't stress enough the importance of engaging your stakeholders all throughout the process and educating them from your perspective, whatever your role is, getting that right information to everybody and making sure that everyone is on the same page. Next slide. That is my contact information. We'll have some time for questions at the end, but feel free to reach out to myself or anyone at our agency here if you want to learn more about our program. So thank you.
Thank you so much, Jen. Again, it just stresses the importance that we have focused a lot on the roadside devices and not as much on the laboratory-based testing. And your lab really has done such a great job with your program. So we really appreciate your perspective. And just as a heads up, we've got a lot of questions in the chat for you already. So we will tackle those at the end. Next up, we've got Stephanie Dellinger. She is the Traffic Safety Resource Prosecutor for the New York Downstate region. And then along with Stephanie, we've got Bethany Solik, who is also a Traffic Safety Resource Prosecutor. However, she's in the New York Upstate region. So I will turn it over to both of you.
Thank you, Amy, and thank you for having us and giving us this opportunity to be part of this important discussion. We know that across the country that jurisdictions are increasingly exploring this evidentiary oral fluid testing that Jen just spoke about as a tool to address the growing challenges of drug-impaired driving. And from a prosecutor's perspective, oral fluid testing has the potential, as Jen mentioned, to significantly improve our ability to present timely and scientifically grounded evidence in impaired driving cases. But one of the key lessons, I guess, that we've already started seeing in the state of New York is that successful implementation of oral fluid testing programs does not automatically translate to successful courtroom admissibility. and not with respect to New York's program, but across the country. And scientific validation and operational rollout are essential. And ultimately, oral fluid evidence will rise or fall on how it is litigated, how it's explained, and how it's understood in court. So my colleague Beth is going to talk about some of the major litigation pressure points that prosecutors should anticipate.
Next slide. Oh, we covered this one. Next slide, please. So there are three major litigation pressure points that prosecutors should anticipate. The first argument is that oral fluid testing represents new or novel science. In many jurisdictions, defense challenges are likely to focus on whether courts must conduct admissibility hearings under general acceptance standards such as Frye or Daubert. From a prosecutorial standpoint, an important distinction must be made between a new evidentiary tool and new scientific methodology. Oral fluid toxicology has been studied and used in forensic and clinical contexts for decades. In addition, confirmatory drug testing in oral fluid programs is typically performed using well-established analytical techniques such as liquid chromatography, tandem mass spectrometry. These methodologies are widely accepted in the forensic toxicology laboratories for detecting and quantifying drugs in biological specimens. As a result, many early legal challenges are likely to focus less on whether the science itself is valid and more on how programs are implemented and how tests are interpreted. This leads to the second litigation pressure point, foundation and program design. Courts will carefully examine how oral fluid evidence is collected, documented, and analyzed. Issues such as officer training, adherence to collection protocols, device validation, laboratory accreditation, and chain of custody procedures can become central to admissibility determinations. Prosecutors who are engaged early in policy development can help ensure that evidentiary requirements are incorporated into the program design from the outset rather than addressed later through reactive litigation. And the third and final pressure point involves interpretation and the narrative of impairment. As with other forms of toxicological evidence, the presence of a drug in an oral fluid specimen does not by itself establish impairment. However, oral fluid testing can be extremely powerful when presented as part of a comprehensive impaired driving investigation. Because oral fluid may reflect relatively recent drug use, it can help prosecutors explain timing and support the overall evidentiary picture that includes driving behavior, officer observations, and field sobriety testing. When integrated effectively, oral fluid results can strengthen charging decisions, support plea negotiations, and improve jury understanding of drug-impaired driving cases. Back to you, Stephanie.
Thank you. And next slide, please. So what should prosecutors and jurisdictions be doing now? First, identify and develop expert resources early. Use your TSRPs. If you don't know what a TSRP is, it's a traffic safety resource prosecutor. Almost every single state has at least one. There are dozens of us across the country, and we have the ability to communicate with each other very easily and identify resources that might be of help to you. For instance, everything that Jen Limoges just talked about, Beth and I can provide you with more information about that from the prosecutorial side. And our contact information will be contained in 2 QR codes in just a minute. We've also requested and started to receive foundational affidavits from forensic toxicologists. Jen has completed an affidavit that we are using in motion oppositions for a Frye hearing. We're also obtaining one. It's ready. I just haven't received it yet, from Dr. Thomas Rosano. Also from New York, he works for a medical college in Albany. And then for those of you that know Dr. Marilyn Hustis, we're in the process of obtaining an affidavit from her as well, with the intent that ADAs across the state be able to include these affidavits in their oppositions to educate the judges, like Jen spoke about, and quite frankly, educate the defense attorneys, because they're making arguments in a lot of cases that are just not legally sound. So that's a huge thing, I think, for your jurisdictions going forward. Second, invest in training. Prosecutors need to be comfortable explaining toxicological concepts, detection windows, and other analytical limitations in a clear and accurate way, even if they're just asking questions of a toxicologist, or if we're talking about summation on a jury trial. You want to be able to explain it to a jury in a way that they will understand, but the prosecutor has to understand it as well. And then collaborate across all disciplines. The jurisdictions that are going to be most successful are those that involve law enforcement, forensic labs, prosecutors, and policymakers in the design and the rollout of oral fluid testing programs. Like Jen mentioned, our working groups have been, I think, very important in the statewide rollout of using oral fluid in impaired driving cases. And then lastly, monitoring case law and sharing the lessons that you're learning. We don't have any reported case law in the state of New York yet, even though we have been using oral fluid now for about a year and a half. I know that the state of Alabama is using oral fluid. We're not aware of any reported case law there either. So we're kind of on the cusp, I think, of this legal landscape. And hopefully that starts to roll in to offer some clarification across the country. And look for the rulings that are both positive and negative, because you can learn from all of those. And then next slide, please. Another thing that we did, and I won't go into too much detail, is that we participated in a CLE last March with our New York State Prosecutors Training Institute. It was a 4-part series with a couple of different experts, including Dr. Rosano and Dr. Hustis. We had a prosecutor that is an expert on FRI hearings from the Kings County DA's office, Brooklyn, do the legal challenges of getting test results into evidence. Her name is Rachel Singer. And we also did, with Dr. Rosano, oral fluid drug testing methodology, the scientific acceptance, and validity.
And then we moved on to the third part of our CLE, which was oral fluid science and acceptability, which was presented by Dr. Hustis. We don't need any more information on her because we know she is a world-renowned expert in her research in this area, and she's synonymous with oral fluid and cannabis impairment. So if you want to learn anything about cannabis impairment, I highly suggest reading some of her work. And then finally, we also had Jen Limoges talk to us about the New York State Police's evidential oral fluid testing program. And the key takeaway I've come to really appreciate in Jen's training and all of this is that she's trained her toxicologists on how to testify. But more importantly, in training her toxicologists on how to testify, she has trained the toxicologists on how to handle new and inexperienced ADAs. New York State is facing several challenges within their prosecutors' offices, specifically in retaining staff and having experienced ADAs try these sorts of cases. And so with having that degree of education and courtroom preparation, they are actually shepherding some of our younger ADAs into the courtroom to adequately and persuasively testify as to the science. So for that, we are eternally grateful to Jen and her lab.
Yes, we are. And the last slide, please. We know that evidentiary oral fluid testing represents a very promising advancement in impaired driving enforcement, particularly in cases where we can't get a blood sample or someone refuses to give one to us. With thoughtful implementation and proactive litigation strategy, we really do believe that it can become a highly effective tool to strengthen accountability and then ultimately enhance roadway safety. So this is our contact information. If you scan the QR code, it'll put a contact in your phone with our information. Feel free to reach out with any questions you might have, or if there's any prosecutors looking for any of the materials from our CLE from last March, just let us know.
Thank you.
Thanks for having us.
Thank you both so much. We really appreciate your expertise, and we know there are other states that have also been through this, but we really like to hear everyone's perspective, and to just hear from New York and hear how it's been for you all has been really helpful for us. So we really do appreciate it.
Thank you.
Thank you.
On to our last speaker, we've got Captain Chris Kinn with the Ohio State Patrol. So he's going to give us a little bit of a different perspective, but some of the same sort of metrics that other states have been using, but it'll be from Ohio instead, which is, I think, also really valuable and why we asked him to come and speak here today. So I'll let you take it from here, Chris.
All right. Thank you, Amy. I appreciate it. Appreciate the opportunity to talk about this very impactful technology that's going to hopefully help us deter impaired driving on our roadways. So next slide, please. When we look at why we would take on something like this, typically in the state of Ohio, we would use urine or blood testing for impaired driving. And go ahead, you can run these stats out for me if you would while I'm talking. So when we look at our problem in the state of Ohio, we can see, at least since 2019, we've tracked our drug impaired driving and our alcohol impaired driving pretty effectively in our fatal crash picture. And we see that impaired driving tends to be more than half, and at least since 2019, more than half of our fatal crashes in the state of Ohio have involved an impaired driver. But drug impaired driving has outpaced alcohol impaired driving every single year. Now, I know we're comparing all the drugs versus one drug, alcohol, but I think that's probably a little bit counterintuitive to what people would think, that most people, when they think of that impaired driver, they think of alcohol impaired driver, when at least in Ohio roadways, our drug impaired driving outpaces our alcohol impaired driving. Next slide, please. So we look back here at these numbers, we can see that our alcohol impaired driving has remained relatively flatlined at 33%, while our drug impaired driving has continued to go up. We had a slight downturn in 2024. Our 2025 numbers will be available April 1st. So we're definitely excited to see hopefully a continuing downtrend in that drug impaired driving. But unfortunately, we know that it makes up a large portion of our fatal crashes. So this kind of outlines some of that problem, and the next slide kind of shows where we're at by drug categories. In our crash report form, we use the DRE drug categories to report the type of drugs that were found in people's system. And I don't think it probably comes to too many shocks to people that cannabinoids are the most prevalent, but we do see that some other drug categories in there. Next slide, please. So when we started looking at oral fluid and how that could be used, there's some obvious benefits of using oral fluid, and those were very attractive to us. I remember the days of stopping someone, somebody that were suspected to be under the influence of a drug of abuse, being a male. If it's a female, I couldn't take a urine sample from them. And, you got to maintaining that visual contact is really important, because unfortunately people would dip the toilet tank and we'd submit toilet water, without that observation time. So no need for that same sex officer violator to keep an eye on people. It is quicker, at least my experience, because inevitably when I would arrest someone, suspect them of using a drug of abuse, they would never have to go to the bathroom. So then we would continually drink water until our time limit would run out, and then hopefully they were able to provide a sample at that time. And Jen talked about some of this stuff. It's a little bit less invasive, I think, to take oral fluid from someone than it is to take urine or to definitely take blood. So, you can see there's a lot of benefits of taking oral fluid that made it a very attractive thing. In the state of Ohio, we have, like I mentioned, we did urine, and there was always challenges using some of those metabolites that would show up in urine and using those for conviction. When we're using oral fluid, we're seeing those parent drugs, especially when we start to deal with that most popular category, the cannabinoids. We see, parent drug, Delta-9 THC, in that oral fluid. So that shows us that recency of use hasn't been metabolized in the body yet. Definitely gives us some confidence in those results. We also encountered challenges with getting search warrants. Since the Birchfield Supreme Court decision, Ohio took the posture that we needed a search warrant for every every blood draw, and getting a warrant in some of our rural counties was very challenging. We don't have widespread e-warrants, and I know back in the days, I can remember standing in a judge's living room at 3 o'clock in the morning. Unfortunately, that's just a challenge for us to do that within the timeframes required by Ohio law. We also encounter a lot of hospitals that don't want to do blood draws for us for various reasons, whether they're busy treating sick people and they don't want to deal with someone that's under the influence, or just they have a hospital policy that they're not going to do blood draws because they don't want to get called in to testify. These are definitely things that oral fluid helps us get over some of those hurdles. Next slide, please. So we worked with the Ohio Department of Health to get oral fluid defined in our Ohio Administrative Code, and then they also, outlined the techniques for testing. And a lot of credit goes to our crime lab. The Ohio State Highway Patrol Crime Lab is not the only toxicology lab in the state of Ohio, but they are the only statewide toxicology lab that services the entire state. And they've done some amazing work to work through that methodology of the screening and the confirmation that complies with the Ohio Administrative Code. One thing that we were very conscious to put in there is the collection of oral fluid and how that should be done. We wrote the law to comply with the manufacturer's recommendations of the device. We use Quantisol in our testing right now, and so we kind of tried to remain, I don't want to say vague, but put that onus back on whatever the manufacturer recommends, rather than trying to write up some policy or procedures ourselves that are going to dictate how those things are, how the oral fluid samples are collected. Next slide, please. So when it comes to the testing, and this was really, again, credit to our crime lab doing this, they follow the National Safety Council Alcohol Drug Impairment Division's recommendations. That was really critical as a good starting point for us to bring this to fruition. Again, anybody that works in toxicology, I can't give them enough credit for getting this process defined and all the work that it took to get there. Next slide, please. So here's our screening tests. We do most of our screening on a QTOF. Is how we're doing ours. There's some obvious downstream benefits of some of the data collected from those things. We are somewhat limited in the state of Ohio when it comes to impaired driving and what they're under the influence on. It has to be defined as a drug of abuse. It's not just any impairing substance. I wish I could give you a very easy definition of a drug of abuse in Ohio law, but it's a little bit challenging. It's a little bit of a circular reference, and it's there's some challenges to that. It's not just any impairing substance. So again, this crime lab, coming up with all those substances was really important. And then we also the confirmation testing too, right? 2 independent methods for testing before we can issue a report that says what we found in this person's body. So definitely a lot of work to get there, establishing both of those tests independently. But, it really is important that those match before we give any sort of data out to the courts. Next slide, please. So we've been running our pilot program now for a little over a year, and we're starting even more widespread. The DREs have been doing it since the very beginning, and now we're starting to rolling it out with our highway patrol posts across the state of Ohio, with the goal of hopefully within the next 6 months getting this rolled out everywhere in the state of Ohio, or at least everywhere that wants it. We're not trying to force it on them, but there are some challenges with it. There's going to be increased challenges, like the previous speakers talked about. Ohio is a very litigious state when it comes to impaired driving, and we tend to testify a lot about this. So we want to be very careful and not try to roll it out too quickly and then get some bad case law down the road. So we are trying to be very conscious, working with our prosecutors. We hold prosecutor seminars to make sure they're educated on this technical part of it. And then our crime lab's always a resource to be to be utilized by the courts. And then we also use our DREs. The DREs are very valuable. Those drug recognition experts, they can offer some consultation to those prosecutors when they're dealing with some of these cases. So it's definitely a big benefit there. Next slide, please. So these are some of these classes we're offering, those oral fluid seminars, training classes for law enforcement on how to collect these samples before we do roll it out in any court jurisdiction. It's pretty self-explanatory using the Quantasol kit, but there are some nuances. I think Jen talked about it earlier where the manufacturer recommends 10 minutes with the Quantasol kit. If you don't get that positive indicator, we're still taking it, and we've had success, especially in some of our early testing of when we were doing blood in addition to oral fluid. We saw a lot of similar results where the results were matching up, even when we didn't get that confirmation that I had that 1 milliliter in the Quantasol kit. We still got some pretty good test results, so we are still accepting that. And then how we get that to the lab, we're trying to keep our samples refrigerated until transport, and then make sure they get down to the crime lab as quickly as possible to get those samples analyzed. And then socializing these concepts where we're going to chiefs of police meetings, we're meeting with our prosecutors and judges, and just trying to take every opportunity to make sure the first time they've heard about oral fluid isn't when they're dealing with it in a case in their jurisdiction. So we're definitely doing a lot of outreach, trying to socialize these concepts, and hopefully this makes a big impact in reducing some of that impaired driving on Ohio roadways. Next slide. So if you have any questions, I'm happy to answer anything about it. But we're definitely looking forward to this new technology, and just being exposed to it as much as I have been. I have a lot of confidence in this, and I definitely see oral fluid being a viable replacement for our current urine testing in the state of Ohio. So with that, I'll kick it back to Amy, and I think we'll take any questions.
Thank you so much, Captain Kin. That was tremendous. And again, we know that there was going to be similar information between the two states, but it was different enough that we absolutely learned something new from both. So I really appreciate both New York and Ohio being willing to be here. At this point, we've got a number of questions in the Q&A, and the regional toxicology liaisons are furiously trying to filter through them. With me today for the RTL program, I've got Sabra Jones, who's the regional toxicology liaison in the Northeast region of the country. I've got Matt Slauson, who's our newest RTL, who is in the Northwest region of the country. And in the Mid-South region is Chris Hartzell. Kristen Burke is in travel gymnastics today, and she's in the western portion of the country, and she may be here, but probably will not be able to help with any Q&A. But at this point, I'll turn it over to Sabra for our first question.
Excellent. Thank you so much, Amy. And huge thanks to Jen, Stephanie, and Chris and Beth for the wonderful presentations. And I'm going to start with a question for Jen. We've got a couple that I think that she can field for us, starting with some of the limitations with oral fluid, including, are there some drugs that we may not be able to detect in oral fluid but be present in the blood? If you can also address detection windows as well, Jen, when you come on as well, we'd appreciate it.
Great. Yeah, thanks. It's normally when I talk about our program, it's about 45 minutes to an hour. So I scaled way back to give you just the high level stuff, but there are definitely limitations. And what I try to really stress is we are not trying to replace blood in impaired driving. This is an alternative. When you have trouble getting blood samples, if it can address those hurdles. And so some of the limitations, it's like I said, it's not a silver bullet. It's one more tool for that officers to have. A couple things limitation wise for us is designer drugs and some of the novel psychoactive substances. We, in our laboratory right now, do not test for those in blood or in oral fluid. We are one of the few states still limited to a Controlled Substance Act. But that can be a limitation in that with blood, if you suspect an NPS or novel drug, you may be able to outsource that testing to an accredited laboratory to get those results. With oral fluid, there's a lot less options for that in having an accredited laboratory that's going to, be able to help with that. So we really try to stress in our training that kind of those routine drugs that you see all the time, your methamphetamine, your coke, your cannabis. If you suspect something novel, you need blood to have as many options for testing. We are doing our program with just qualitative analysis, so that's present or not detected, versus our blood testing is quantitative, where we give an amount. An important thing to understand is that the drugs are present in oral fluid basically for two different reasons. One can be they're present in the blood, circulating through the body, getting into those salivary glands and coming into the oral fluid from what's in the blood. But they're also in the oral fluid from the coating of the oral cavity. And a lot of the drugs that we see in our impaired drivers are used orally or nasally. So snorting, sublingual, smoking, all of those ways coat that whole oral cavity, and you can get very high drug concentration levels in that recent exposure time period, but they don't correlate to what the levels are in blood. We try in our trainings to remind attorneys and other people that a blood level does not prove impairment. So while that gives us more information, we can talk about that's consistent with a therapeutic use or not consistent. Even using a drug properly and being in the therapeutic range doesn't prove someone's not impaired. And taking that drug and your levels are a little higher than therapeutic doesn't prove they are. So we try to remind them the limitations of blood testing too, but there's definitely more info that you can get in that. That's why we're not looking to replace it. But some of those advantages in the collection and for law enforcement really have a purpose here in our state. So that's why I really stress identify what your problem is before finding that solution, and see if oral fluid can address some of your problems and challenges.
Thank you so much, Jen. We're at least I'm furiously scrolling through just to make sure. I think you've actually hit a couple of the questions all at once within that answer, so we really appreciate it.
One important one, I saw a couple of the sample we get in the lab is independent of the sample from a roadside screening device. So if you use a screening device at roadside and collect an oral fluid sample, it's a completely separate collection process for the evidential sample. You can't take the one you collected for roadside and send that to the lab with most of the products that are out there. There are some that are looking to do that, but that's not the kind of collection device we're using in our state. So make sure that you understand that in your program.
That's a great point. Thank you so much. Matt, did you have any others in the chat that you wanted to tackle before?
Sure. Keep Jen on the line if that's okay. I think we can maybe bundle the next few, and I'll repeat them if need be. And it's about New York having time limits in their statute to obtain a sample. I'll go one at a time just to hit them all, but they're hopefully quick.
You know what? Can I punt that one to Stephanie or Beth? Because people talk about a 2-hour rule, but it's not really. So I'm going to punt that one.
Okay. And then in your story or in your presentation regarding the exact match, you've kind of already talked about how you reported qualitatively. So I'm assuming you got a qualitative result and that constituted a match. Yeah.
Yes, we were comparing match as far as just positive or not detected.
Okay. And then the percent of refusal, have you noticed any changes in that since moving to this type of sample?
I don't have any data yet. That's stuff we're hoping to collect and see how that looks. One of the NACID members, ITSMR, Institute for Traffic Safety Management and Research, tracks a lot of that for us, especially with DRE data. So it's too soon to know yet if we'll see any of that. All I know now is anecdotally, law enforcement feels like they have more cooperation.
Great. And then this will be a good little segue to punt to the TSRPs. With the prior question regarding the basis for which the FRI hearings were denied.
That one I'm going to punt to them too.
So we've got 2 punts to our TSRPs.
Yeah.
I'll take the time limitations question if Beth and if not, let me know. There's no real limitation on the actual collection of a sample. We do have this 2-hour rule that really only applies to chemical test refusals. So if someone's going to, we have a set of consequences that have to be read to somebody if they're refusing to take an evidentiary test. And those warnings, consequences, whatever you want to call them, have to be given within 2 hours of the arrest, and the refusal has to be done within 2 hours. But if someone's consenting, they can consent at any time and they can provide a sample at any time. But if the refusal is outside of 2 hours, we can't use the refusal for consciousness of guilt. So we always want the request to happen as quickly as possible. And then obviously for evidentiary purposes, the earlier it's collected, the better the sample result will be.
And then turning over to why the Friday hearings were denied, the courts really aren't issuing any reasoning with their decisions. All the decisions actually have been just from the bench saying denied, 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 with no reasoning behind it. So I don't have an answer for that question.
Great. Thank you.
Thank you. Chris, did you have any in the chat that you wanted to pull out, or the Q&A?
I need to unmute myself. That would help quite a bit. Looks like Tom Brady, and I'm just going to leave that right there for everyone to think about, is asking, in Florida, a warrant is required for body fluids. How can oral swabs be used in field testing and circumvent a warrant? Question mark. Also, what about THC testing and the determination of impairment from THC recent use? So I guess maybe Jen, would that be for you? Or
Yeah,
you can punt that one too if you want.
I can talk a little about the THC testing and determination of impairment. For us, the way our experts testify in cases is we do not state that the defendant individually was impaired. That's our expert opinion. We don't state that. We talk about the testing, the reliability of it, how that drug can impair driving. And then the case is built off the evidence of impairment from law enforcement, witnesses, driving behavior, all those other things. So for us, whether it's blood or oral fluid, we're not going to say that result proves that the tox result on its own proves that a subject was impaired. So that's why we like oral fluid instead of urine, in that it is more recent use detection window. And so while you can't say they did it 2 hours ago, it is much different than detecting carboxy THC in urine. You are getting parent drug, and it has that closer window of detection. As far as warrants work, I think that's different in every state and how that plays out. But I'll let Stephanie or Beth add to that if you have anything on the warrant question.
Yeah, so our law only requires a warrant if someone has refused and they have caused serious physical injury or death. That's actually the only way we can compel any sort of chemical sample, biological sample. And if we're going to do that, we're getting blood. We're not going to do oral fluid. We can ask for a chemical test, actually of anyone, but we cannot require it or read the consequences of refusing if they're not under arrest for DWI or impaired by drugs. So it's a little different here, I think, than in Florida.
Thank you.
Okay, I think go ahead, Chris.
No, go ahead if you have something.
No, I was just going to go on to the next question.
Okay, go ahead.
Okay, awesome. And I think Beth and Stephanie, you already mentioned Jen Safaldi, the TSRP out of Illinois. She was wanting to get copies of the foundational motions, if that was
I saw
possible.
that. We'll send her some stuff.
Okay,
And
awesome.
hi, Jen.
Thank you so much. Okay, the next question, going to Jen, are there drugs that you are seeing regularly in blood or urine samples for misdemeanor, non-injury cases that you cannot identify in oral fluid? And then how significantly will not pushing for blood samples or trying to continue to show the reliability of urine samples combined with the DRE program affect the identification of impaired drivers? For example, those drivers using a pill or IV forms of drugs.
So the first part, we are not seeing any significant trends with a drug being detected more in the blood versus oral fluid or vice versa, except for 6-acetylmorphine, which is kind of your marker of heroin use. And we have a pretty low detection limit in blood for 6-acetylmorphine, and it's rare, if ever, that it triggers a positive. But we are seeing it quite a bit in our oral fluid samples. So it does actually, oral fluid seems to provide a little bit benefit in the success tail morphine marker. But other than that, we really see a good correlation in positive between the two, which supports a lot of the studies that are out in the literature. We have the same scope of testing for both matrices, both sample types. So it's from a customer standpoint, they're not necessarily getting more or less in the scope of testing per specimen. Like I said, the limitation could be if we needed to outsource for a drug we don't test for, those options may be more limited for oral fluid outsourcing versus blood. As far as the urine samples, urine is in our statute. It is a prosecutable type of case. We just educate people that there's less a toxicologist can talk about with that. But when you have a drug recognition expert evaluation that, is well documenting the impairment, you have officer observation, all those things, and you have a drug test result with a substance for us that's on our controlled substance list, that is still a case that is viable in New York and can be prosecuted. Oftentimes in our state, agencies collect urine because it's easier than blood. And so we're shifting away from that because we feel oral fluid is easier than urine, as our law enforcement presented, that you don't need that gender matched observation and things like that. So we feel like it can shift the reasons you would use urine, oral fluid provides those benefits and more, in my opinion. Like I said, we're not trying to replace blood, but we do think that it could potentially phase out urine as a better sample for impaired drivers, but not in any way saying urine can't be used in cases. That depends on your state. Florida is obviously a big urine state. We've gone down very much in our submissions of urine, but those are still out there. So this is another option.
Okay, I think we have time for one more question, and this is regarding the Ohio stats that were presented. Do those include those who had both alcohol and other drugs in their system? And also, will the oral fluid test capture alcohol?
So our testing when we're testing oral fluid, we're only testing it for drugs of abuse. We are not doing any testing for that with alcohol. The alcohol would just typically be done with a breath test. And then those stats kind of break down a little bit of what the alcohol and the drug problem was in the state of Ohio. But that 54% is everything. So obviously, if you add those two numbers together, it equals way higher than 54%. That's because we see a lot of polysubstance use where they're mixing alcohol with a drug of abuse. So they kind of tick a box in both categories.
Thank you so much. We are at the time, and if the Q&A is any indication of just the interest in this alone, I think we may have to consider doing a part 2. We really appreciate all of your time for our experts on our panel. We know that you're very busy people, and we just really appreciate that you carved out time to be here with us today. We also appreciate all of you that came with us today and attended. As Christiana said at the top, there will be a recording of this webinar. So I know there were some folks that registered but couldn't make it, but at some point down the road, there will be a webinar that will be distributed. So thank you all again for your time and your expertise, and please take care.